So when I was given this title, I read the first line and it says nutrition through the ages. And as a francophone, I thought I would have to do nutrition from the medieval age. And then I look at the other lines from pediatrics to teens to pregnant women and aging adults. And I said, oh my God, what did I get into? So, and in 20 minutes. So what I will do is I will try really my best, and among the disclosure, I must say also that I'm not a pediatrician or an obstetrician, but a gastroenterologist. So what I will do is that we heard a lot about obesity and metabolic syndrome, but in my methodology of trying to prepare this talk and looking at systematic reviews that were published over the past 2-3 years, really a lot of literature is on obesity. So I'm going to touch again on obesity and try not to repeat what was said before, and really also talked about these recent systematic reviews. And if I have time, I'll talk about malnutrition, but it's possible I don't have the time. We'll see how it goes. So those are my objectives, and I didn't mention that we'll also review some of these systematic reviews. So when we look at obesity, it's a problem, as we know, and by year 2015, it is predicted that worldwide there will be 2.3 billion adults with overweight and 700 million adults with obesity. And some of these statistics have been presented by Dr. Ledin. Essentially, it's to show that there's a progressive increase in the prevalence of obesity in the overweight population in Canada. And this is mostly across the province. We see this trend. And it's affecting all age group, but mostly, I would say, from the age of 20, we'll see 20 years, up to 75, we see that it's progressively increased with a maximum around 55, 64-year-old. And this is both for male and female. Now, what is worrisome is that not only we have this increase in prevalence of obesity, whether it's in terms of class 1, class 2, or class 3, but there seems also to be an acceleration. If we look at this curve here, it's almost like it's going on an acceleration trend. And so that is really worrisome because it means that there's more and more every year. Now, we heard that obesity, there's multi-factors contributing to it, and essentially what it is a genetic predisposition and an interaction with an increased energy intake and a reduction in energy expenditure. And that will increase energy partitioning, favoring fat accretion and adipogenesis, and then will lead to obesity and overweight. Now, when we look at the reduction in energy expenditure, this is one of the benchmark studies showing that there's actually a very significant reduction in energy expenditure when we compare our lifestyle with our ancestors. And here it's a really similar lifestyle with the primitive hunter-gatherer farmers versus the sedentary adult in the U.S. And what you can see is that when you compare it for male, you have a reduction in 42% of energy expenditure just because of this reduction in physical activity, and a reduction of 27% in women. With this, you have actually a significant increase in the diameter of the plates you eat, so that with food in it. So you see that significant trend in oversized portion that goes with this reduction in energy expenditure. Dr. Gigi Boy mentioned the genes, and it is true that we are the descendants of ancestors that really survived droughts and famine and food deprivation. And because of this selection in genes, we have the genes that actually really favor storage of energy and favor us in environment of famine. The only problem is now we really have this environment of plentiful. And when you look at genes, those are really selective list of genes, but they are associated with obesity phenotype based on skin fold thickness, BMI, waist circumference. And these genes affect metabolism, or they can affect leptin, for example. And in fact, there are various types of genes like this that affect all the different physiologic aspects of from eating to absorption and signaling for satiety and hunger. And you have some of the examples here of hormones. And for example, leptin, which usually is a satiety hormone, then will signal you to reduce your intake. And you have ghrelin, for example, which is a hunger signal. And you have the vagal also nerve that is important, and there are stretch receptors in your stomach. And when you eat a large amount of food, it's going to send a signal to your hindbrain to say, well, it's enough, and you can stop eating. The problem with this is that you don't have really sensors for the amount of calories you're eating. So when it comes to food density, and if you eat a small portion, but it's extremely dense in calories, like if you go to fast food restaurants, for example, your physiology is not going to sense that. It's kind of going to sense, in a way, in the stomach, the volume of the food. And then if you eat very high-density food, you're going more of it before you really feel that you reach a point of satiety. And this is a problem. And this was really an interesting study I came across where they actually look at dietary energy density and body weight in adults and children. And this is a systematic review. So you have on the left, it's kind of saying that we review like, many, many papers, and then we had some methodology criteria, and then we ended up at the end with about, 16, 20 papers for adults and children. And the main message there is that they found a positive association between dietary energy density and increased adiposity. And so the more you were eating of these energy-dense food, the more likely you were obese because you eat more of it before you sense that you're full. And they also found a strong and consistent evidence that diet low in energy density improve weight loss and weight maintenance. And so they suggest, based on this evidence, that diet low in energy density may be effective in managing body weight in children, adolescents, and adults. So those is really when you increase the fiber intake, content of the food, for example, to reduce that caloric density. Now, another problem that we heard from the previous speakers are the added sugars in the pediatric obesity. And there was also a review on this recently, looking mostly at the pediatric literature. And what they found actually is that it's still a good proportion of the calories that children and adolescents are eating, close to 15% here. And they say that the largest contributor of added sugars to American diets are the sugar-sweetened beverage. And adolescent is the highest consumer of these beverages. And of course, you have a long list there of added sugar that may be found on food labels. And if you have people that don't have really a lot of education or are not really knowledgeable in instruction, sometimes they may have some difficulty to find whether they're dealing with added sugar or not, particularly something like dextrin, dextrose for these people. And when you look at the amount of calories, for example, here you have all the different soft drinks on the left, and you have the amount of calories per 12 ounces. You can see that it could be a significant amount of calories as sugar, and you have here the total sugar content in grams. And this is particularly interesting for fructose, which is often a large part of this amount of sugar, anywhere from 22 gram to 21 gram. And of course, other drinks have much lower amount of this. And the interesting thing about sugar is that fructose, which is shown here, is that it doesn't trigger insulin. It doesn't lead to increased glucose level, and it doesn't increase stimulation of insulin. And usually when you eat carbohydrates or sugar and you stimulate insulin, insulin also sends signals to leptin to increase and send a signal for satiety, for example, so that you can stop eating or drinking. But if you take a lot of fructose, that signaling is not sent to your brain to say, well, you had enough, you stop eating. And so that's a problem of fructose, and it leads to overconsumption because you just don't feel it. And the other thing also is that it's associated with liver steatosis as well. The other thing we mentioned, and Dr. Pediatric mentioned the intestinal microbiota, is of course the type of sugar and carbohydrate that you're eating, and also the amount of fat versus carbohydrate is going to influence the intestinal microbiota. And there are studies showing that it's different in obese patients compared to lean individual, and there's a ratio of Firmicute bacteroidetes that has changed. And this is very interesting because depending on the proportion of bacteria you have, it may also influence intestinal permeability and produce some endotoxemia, and that may lead to insulin resistance and diabetes. And there are certainly a large amount of animal studies that are reporting this. So again, nutrients influencing intestinal microbiota, and that can lead also to diabetes and obesity because some of these microbes are also involved in energy salvage. And I'm not going to say a lot about intestinal microbiota. We mentioned, or microbiome, we have mentioned other causes that may influence it, and that will lead either to a symbiose state or dysbiose state. And we just want to mention that it's also associated with disease, as Dr. Pediatric mentioned, like inflammatory bowel disease, diabetes, as I mentioned, which is associated with obesity, of course, and other disease. And in the pediatric literature, we can see there that the change in the intestinal microbiome also is associated with various types of disease in the pediatric population. So now to come back to the obesity, we know that these obese patients really utilize the healthcare system much more than lean individuals. And this is just here an example of the increase of consultation to family physician, and it's the same for a subspecialist. Here it's with women, but it's also with men. And the reason I mention women here is because I'm going to talk also about obesity and pregnancy. So when I did my search of the literature, there was a review in Gynecology and Obstetric Journal looking at obesity, maternal obesity, and its implication for pregnancy outcome and long-term risk, and also the link with maternal nutrition. And this is becoming a problem. So first, obesity reduces fertility and fecundity. It's associated with more hypertensive disorders during pregnancy, gestational diabetes, respiratory complication, and thromboembolic events. It's also associated with slower labor progression rate, higher C-section, more surgery-related complication. And from the fetal and newborn perspective, complications are increased in terms of congenital malformation, large for gestational age infants, stillbirth, shoulder dystocia, and it's even having an effect in adolescence, during adolescence of these children with obesity and diabetes. Now, of course, when women are seen and are pregnant and are obese, this is not the time to have them do a weight loss diet or medication to reduce intake, of course, and definitely not bariatric surgery. But this is where it's important to do counseling and increase physical activity. And there are several studies mentioned in that systematic review that showed that physical activity and health healthy food choice really improve outcome in these women, and that it's not necessarily weight loss, but it's more like healthy eating and exercise that improve the outcome. Now, the other thing I want to mention, I didn't mention that this thing of obesity in pregnant women also is transferred to adolescents. And when I did a lot of work for you guys and girls, because I look at the literature, and it was very interesting for me as well. There was this systematic review looking at what's happening with puberty. And if you look at the literature, there's some concern that the more and more there's earlier and earlier age for puberty. And so here they look at puberty. And why is it important also? There's a public health aspect of it, is that the earlier you have your puberty, you may be at risk later on to have hormone-related cancers, higher risk of all cause of mortality later on, metabolic syndrome, and cardiovascular disease. I didn't know that. So that was very interesting. And so they're looking at whether there's any modifiable factors influencing the timing of puberty, because this could be a public health issue. So childhood overweight has been linked with earlier puberty, but this is not universal, as I will show you in the next couple of slides. But there has been also observational studies suggesting there may be association with certain dietary intake and the age of onset of puberty that has nothing really to do with that energy imbalance. So this is the trend, the secular trend of weight changes. So you can see the prevalence of overweight. It's increasing over the years. You have the different countries, and you have Canada just here. You see how it's going. Okay, so significant increase in the prevalence of overweight over time, and this is for children aged 4 to 12. Now, if you look at certain countries, there is an association with reduced age of onset of menarche. So this here is menarche for this age group around 10 to 14-year-old, 10 to 13-year-old. And you can see that difference here in age going over time, suggesting that there may be an association with this increased prevalence of overweight. However, it's not the same for all countries, and some really haven't seen any change in the age of puberty, and others maybe a little bit increase or decrease. So there seems to be other factors to this. Now, I'm not a huge expert in this field, but there are other factors, there are many factors influencing puberty. And first, there are some psychosocial stressors and chronic, if the patient has a chronic disease, malnutrition, or there's intense physical activity that may influence it. There is intrauterine deficiencies may later on also affect the age of puberty. There is the rapid weight gain. Breastfeeding apparently also has an influence for puberty. And all these work on these various hormones that, estrogen and phytoestrogen, the estrogen and insulin and so on at the back, which I cannot really comment a lot on. And then you have the body fat. And finally, you have the dietary composition. And it looks like, depending whether you have a higher amount of animal protein or lower amount, or you have a higher intake of phytoestrogen or lower, it's going to influence the age of puberty. And in this review, when they look at all the body of the literature, they found that children with highest intake of vegetable proteins have pubertal onset up to 7 months later than average, the current average, so appropriate age maybe 20 years ago. And children with highest intake of animal proteins are 7 months earlier than the average. And when they look at the girls specifically, they found that girls with highest isoflavone intakes, like from legumes, may have onset of breast development and peak height velocity 7 to 8 months later than average, which is also more favorable. So the conclusion of that systematic review was that the dietary patterns characterized by this higher intake of vegetable proteins and isoflavone and lower intakes of animal proteins may contribute to lower risk of breast cancer and lower total mortality, because they're transposing that to what's the effect of puberty later on. So that could be something of significance. Now, when we look at, and there were a couple of questions about interventions, and so when I did this literature search, I was interested to look at intervention from the public health point of view. What could, affect population in terms of their intake? And so here they did a systematic review on the effectiveness of school-based nutrition education intervention to prevent or reduce excessive weight gain in children and adolescents. And so they look at all the studies that were done in this area and whether or not they were effective in improving anthropometry, like reducing BMI, reducing weight, or they were effective in improving the dietary intake of the adolescent and children by increasing fruits and vegetables. And they found 24 articles there. And actually what they found is that the school programs actually were effective to reduce overweight and obesity, as well as increase fruits and vegetables consumption in the best conducted studies. And the best conducted studies were when the intervention was more than 1 year and where it was introduced as part of the regular curriculum and school regular activity, where there were parents' involvement, and where they also had a provision of fruits and vegetables by schools' food services. So I think this is probably a very interesting thing to do from the public health point of view, and has already started with food program in schools and things to really improve the dietary habits of these children and adolescents. Finally, there's this other intervention which actually, based on this systematic review, which, by the way, is a Canadian study, seems to be very powerful. And this is the nutrition labels on prepackaged food. And what the objective of their study was to review the research on consumer use and understanding of nutrition labels, as well as the impact of labeling on dietary habits. So they did a systematic review, and at the end, they ended up with 120 articles that really look at assessing the consumer and the consumer perception and habit regarding this nutrition labeling. And this is the summary of their results. So what they found is that nutrition labels are among the most prominent sources of nutrition information for the consumer when they assess the consumer based on that systematic review of all these studies. Nutrition label is perceived as the highly credible source of nutrition information. Many consumers use nutrition label to guide their selection of food products. And there's a consistent link between the use of nutrition label and healthier diet. However, the use of these nutrition labels really varies between subgroups. And lower use are among children. It's not surprising. You need almost a bachelor in science to read sometimes these food labels. And adolescents are also not reading that at all. And older adults who are obese. And really the challenges in terms of consumer is to understand and also to use appropriately the labeling information. So the conclusion of that systematic review was that nutrition label on prepackaged foods are a cost-effective, population-level intervention with unparalleled reach. And I think this is very, very important if we want really to change the way people eat. To capitalize on their potential, governments will need to explore new formats and different types of information content to ensure that nutrition information is accessible and understandable to all this population. So I think that was really an important review, and it was Canadian. And I think this is certainly intervention that can influence the population. Now, I'm going to switch to malnutrition for 5 minutes. I have 5 minutes left? I'm still 5 minutes left. Okay. So quickly about children, there's also issues of malnutrition. And some of the most frequent diseases that can really produce malnutrition is things like celiac disease, cystic fibrosis, Crohn's disease, and of course other type of disease, psychosocial and psychiatric, also may influence malnutrition. And when you look at common underlying diseases associated with failure to thrive, celiac disease seems to be something that is quite important and frequent in that population. And it is also about affecting 1% of our population. So I think that, I thought I would just mention it very quickly. And for some of you who don't know, celiac disease is characterized by small intestinal mucosal injury and nutrient malabsorption. And it's in genetically susceptible individuals following the dietary ingestion of gluten. Okay? Now, that pathogenesis involves the interaction between genetics, environment, and immunologic factors. Now, I'm going to bypass this just to say that it has to be a genetic predisposition. And in addition, you need some kind of stressor, or you need infection, mechanical or chemical stressor that will then affect the permeability. So I think someone was mentioning about leaky gut, affecting the permeability. And you may already have a predisposition for increased permeability. And this will allow the gliadin from the gluten to get into the submucosal and trigger an immune reaction that will produce the villus injury. So there was one study done in children, again, a systematic review, and by Alessio Fasano with the Swedish collaborator. And they looked at whether what were the factors that could predispose to celiac disease, and particularly in children. And they wanted to do this review because there was an epidemic of celiac disease in the Swedish population when they really changed the way they were introducing gluten, like earlier and probably larger amounts. And you can see that peak there in the children who are up to 2-year-old, where you had that sudden increase in diagnosis of celiac disease. And in a nutshell, what they found when they look at breastfeeding is that in a systematic review is most, but not all studies, suggest that breastfeeding reduces the risk of future celiac disease. But those are mostly retrospective studies. It is unclear if the protective effect is persistent or represent a delay in the diagnosis of celiac disease. It's too early to say. And the mechanism is not quite clear. When they look at the timing to gluten introduction, they found 2 large Swedish studies that didn't show an association between the timing of introducing gluten and the celiac disease. However, the amount of gluten could be associated with the onset of celiac disease in children less than 2-year-olds. So the amount rather than the timing. And so currently there are some prospective studies looking at desensitization diet and also factors, environmental factors that can affect celiac disease. I'm just going to take the last 2 minutes to talk about malnutrition in older adults, because we know that with the demography and the statistics that we were shown earlier, that there's really this baby boom, there's really a significant increase in the older population. And there are several factors that affect malnutrition in the older adults, as we can see there, from chronic disease to polypharmacy to psychosocial. One thing that I want to bring up is that there's also a large proportion of patients in the hospital that have malnutrition, anywhere from 30 to 70%, and this has been shown in several studies outside of Canada. There are several factors contributing to malnutrition. There are those that are before the patient is admitted, and there's also those during admission when the patient is not properly screened, monitoring sometimes fails, there's a lack of perception, a different perception about what is malnutrition, and then of course during hospitalization, multiple tests, reduction in intake, and so on. So, and this is important because malnutrition affects outcome in patients in hospital. It may increase mortality, increase treatment, length of stay, and all this, of course, drives cost significantly. There's many studies showing that. So here we put together the Canadian Malnutrition Task Force, and we wanted to look at our Canadian hospitals and how prevalent is malnutrition, how is the nutrition care, how does it affect our patient. So essentially, we look at prevalence and the several outcomes and look at the type of nutrition care they have. We essentially found, based on subjective or global assessment, that roughly 40% of patients are malnourished at admission. And you see there the 9.2% plus the 32.3%. Those are mild to moderate to severe malnutrition. So significant malnutrition based on subjective global assessment. It's also what we found in terms of factors that are associated with early discharge, and including comorbidities and presence of cancer, but not terminally ill patients, is that in addition to age below 60, patients who eat more than 50% of their food on their plate, and those who are well nourished have a much early discharge. And that's independent factors, independent of comorbidities. So that's really important. The other thing we did is a patient satisfaction, and I'm just going very quickly to mention that in hospital, there's a proportion of patients that have difficulty reaching their food, poor position for eating, they cannot open packages. 34% had difficulty opening packages and unwrapping their package when they were eating, or they didn't get their food when they were in the room. And hunger in hospital is still a problem. Close to 30% of patients actually had food brought up from visitors to eat more because there was not enough food. 8.5% had no food available when hungry, and 23% had time between meals that were too long. So, and another proportion never received meal from hospital staff when the original meal was missed. So there's a lot of things also in the hospital we can correct that it doesn't seem complicated to improve intake in our patient population. So I'm just going to skip that and just conclude because of time. And mention that this is kind of a little bit of, I don't know if I called it a sprint or a marathon, but as you know, prevalence of obesity is high. It affects all age group, and it affects outcome. It's complex, and really it needs a multi-pronged approach, and I hope I gave you some type of interventions that may help reduce the prevalence. But we have to think also that malnutrition is important and is prevalent, particularly in hospitals, and that both are associated with chronic disease and affect outcome and the impact on our healthcare system. So we really have to address both together. Thank you very much. So, any questions? And I cannot guarantee I know all the answers to your questions.
Thanks, Johane. That was great. A comprehensive review. We're incredibly and strangely right on time. I don't know. So we're going to take just a couple of questions, and then people are going to have a well-deserved break until about 3:45. I think somebody at the front.
Hi, I just wanted to say that was a lot of information you delivered, and it was very interesting, and well done.
Thank you.
Thank you for your presentation. Earlier on, you made the conclusion that excess fructose leads to overconsumption. Can you expand a bit more on the clinical trials, the human clinical trials that statement was based on?
In terms of the fructose?
Yes.
I cannot, it's mostly on systematic review. I cannot give any specific trials.
Are they animal studies?
It's more on the fructose, the fact that fructose does not simulate insulin, and insulin usually signal leptin to send signal for satiety. But in terms of specific studies, no, I cannot comment on that. Unfortunately, I'm not a fructose specialist.
But it's not based on humans.
I'm sorry?
It was not based on a human study.
There are several studies done on that. There are several studies. Fructose is becoming an issue, and that's because it's not sensed really by your body. And has also been associated with fatty liver. But in terms of trial, whether you do fructose or no fructose and you look at outcomes, I cannot comment specifically on one study, particularly with that breadth of talk.
Thank you very much. Just a comment about the hospital-based malnutrition or suspected such. Hospital wards, certainly now, I'm a physician who practices in Brantford. And in my hospital, the wards have become basically areas where, in fact, if there had to be an evacuation, I don't know how it would happen. Between the technology that the nurses have to cart around with them to enter information, the nature of the fact that almost every room you have to gown and mask because there's either enteric or air-related precautions, and these are folks that can't open packages or, in fact, can't even eat their meals quite often. I'm into a room to see someone, and they've probably had their breakfast and half their lunch still sitting there, and either a health professional or a family member hasn't been able to help. I'm just thinking that maybe we need, in that particular population, in that particular instance, sort of a relatively large-scale plan to improve that problem, because it's a logistical and it's just a factual problem of how medicine is practiced and how wards are organized in this day and age.
One thing, and I'm sorry with the echo, I may have not captured everything you said, but one thing we were thinking in terms of strategy to try really to help particularly the elderly patient. We have now a larger and larger proportion of elderly patients in our hospitals, and is to have a training program for volunteers. And it's apparently that in some area it's already existing where volunteers are doing particular tasks at bedside. And I think that we should expand this and look at training specific volunteers who are there to help. And of course, we'll be able to identify problems if patients are eating or, be a little bit knowledgeable. But apparently some programs like this exist already for specific patient population, like I think dysphagia population. And I think that we should think more about using our volunteers and train them and help at bedside. Yeah.